which is usually about 8 p.m. because our folks are coming from far, far away, and if they come from that far away, we want them to have the opportunity to be seen. I have seen things in the OPD I never even had on my differential diagnosis in residency. This is just a random case from this past week of something that I have never even thought of on the differential prior to this. Eye problems, oral ulcers, genital ulcers, pathergy. Whenever he gets like a cut, he has a bad reaction. So this was like Behçet's syndrome, which to me only existed in tests and like old notebooks, right? And this happens constantly on a daily OPD basis, if not multiple times in the OPD in rural Chhattisgarh. So my original, very arrogant assumption has been proven extremely wrong, and this has almost been like a bonus to residency, being at this site. The things that I've seen, not only in terms of diseases I would have never had the chance to see, malaria, but things I could have in varying degrees of their development or lack of development, and their severity has been mind-blowing. Now, part of my job at JSS is to educate the family medicine residents, which is why I'm here. That's my connection to family medicine. And I was astonished, like, every day we see things that I may never ever see again. I saw someone with a new diagnosis of tetralogy of Fallot at the age of 50. As far as I know, I've never even heard of anything like that. And then, like I'm saying, this happens regularly at JSS, which is what I'll call where I work. And I was struck by how do we use the incredible amount of incredibly intriguing and interesting academic information and kind of mine, for lack of a better word, mine that information, mine that wealth, and sort of use it to model lifelong learning. Because we're seeing things you'll never see again, and you probably have never seen before regularly, in addition to very common things. But then I was also struck. Residents where I work, like residents probably everywhere on planet Earth, are working very hard. They have OPD responsibilities, they have emergency responsibilities, they have OT responsibilities, inpatient, outpatient, thesis, coming to conferences and trying to present. So how on earth do we strike a balance with attempting to mine this incredible wealth that's in front of us while also being respectful of the fact that residents also need to be human beings? And they shouldn't be falling asleep on OT tables like this person is. So it's really a question of how to sort of maximize using the incredibly rich pathophysiology that we see in Chhattisgarh with the limited amount of time we have. And along those lines, this was sort of where this thought process was conceived. Patients in Chhattisgarh are remarkably willing to be videotaped or have their photos taken for teaching. Everyone who's involved with this picture club, of course, provides verbal consent. I don't get written consent. But the way this works is we lay out a case of something interesting, like Behçet's disease or like this young woman, and we just sort of talk about it in a stepwise approach, one picture or one video at a time. So if you look at this, this is not a particularly difficult case, but thick purple striae, obesity, evidence of insulin resistance. That's supposed to be acanthosis nigricans, but my camera isn't good. What is this an example of? Yeah, so this is a hypercortisol state. And then we just walk through it at JSS. So you can ask someone sort of, what's the initial workup? And one of your bright young residents will say, well, you can do like a midnight saliva, you can do a low-dose dexamethasone suppression test, you can do a 24-hour urine cortisol level. Well, none of those things are available. So where do we go from here? Because we don't have those opportunities. And that's really where the learning comes from. Someone might bring up, well, could it be medicine-induced? Is there something we could talk about that maybe we could address in our setting and save this person a referral to Raipur or Bilaspur? In this case, it actually was medicine-induced. She's now on a long-slow steroid taper, and she's actually doing a lot better. But then we'll talk about, what would you do if she hadn't been on medicine? Someone will say, I would get a cortisol. We can send that away even though our lab can't do it. Well, then we talk about the diurnal variation of cortisol, and we talk about, so you say you get it at 8 a.m. and it comes back 30. Would you still not do the next test? Would you? It comes back 400. What would you do? There's no right answers, and the entire purpose of this is to get the residents and the group to sort of talk about this. So this is just kind of a classic example, and we just use pictures and video, and we just use our own patients. I've never ever had a week where I didn't have more cases than I needed. Never ever had to go to the internet or use anything from the past. It's actually surprisingly not difficult to pull off. The residents asked for this to be done on early Saturday evening, as it's a quieter day. It's an hour-long period. We usually do 5 to 6 cases, so it's about 10 to 12 minutes a case.
So you have 1 more minute? 1
more minute, and it only takes me 2 to 3 minutes to do, in addition to photographing people in clinic, which they provide support for and the verbal consent for. I think it has a lot of noticeable benefits. Works with differential diagnosis building, clinical decision making. We talk about very, very recent cases every week. We're reviewing the past week's cases. And it's sort of a space where, because it's Saturday night, none of the senior consultants can be there, so it's a little bit more of an informal setting. That has positives and negatives, but I think more positives than negatives. And I say that with one of the consultants in the back of the room. My concerns. Obviously, we're doing more breadth than depth. 5 to 6 cases an hour, you're moving pretty quickly. And every week I must decide, should we do something common like diabetes or something crazy like Behçet's? Where's the value, sort of physiological interest versus other stuff? Our goals are to work this into the curriculum and eventually make it resident-led, resident-based amongst the third-year senior residents. We don't have any third years yet, just second years. The residency's only 2 years old. That's it.
Thank you. Any questions? No?
So, tell me about the origins of the cases. Are they cases that you pick or that the residents bring?
So it can be either or. I sit in an OPD on Monday, Wednesday, and Friday, so I already have, in a given day we have between probably 20 to 50 people in each OPD, so there's inevitably probably 5 to 10 people I photograph just in the internal medicine OPD. On the inpatient service, I'm also getting everything else, and the residents also take photos and forward them to me. So we're kind of all sort of using the information available to us. Most of the cases, I guess I would say I provide, but that's just sort of how it's been initially. It doesn't have to be like that forever.
And have you thought about how you might evaluate the program?
It's a really, really good question. How would you show this potentially being of some value? I have not really thought about how to go about evaluating this. It's kind of hard to evaluate more informal sorts of settings. So no, I don't have any great insight.
Do you serve food?
No, I do not serve food. Don't get any ideas, guys.
Sometimes that attracts people to come. And what's your attendance like?
So we have between like 5 to 8 trainees at a given time who are there. Obviously clinical work always trumps it, so sometimes there's a road traffic accident or there's an ongoing operating theater case. But if free, most people usually make it. Is that a fair statement, guys? Pretty good attendance? All right.
Anyone else?
I have one more question. Can you move beyond pictures? Can you anticipate discussing topics that don't have a picture?
So this is a good question that is sort of tricky to work around. Thus far, it hasn't become an issue because I have so many pictures to sort of draw from. And I don't have, we could try to make it more case-based, I imagine, in the future. And I guess I could incorporate pictures of like lab test results or everything. But right now it tends to be very physical exam heavy because it needs to be something that's photographable or videotape showable. I do think I have the capacity to do that, but it hasn't been an issue just because there's rich wealth of information. But I appreciate that.
Thank you.